Good afternoon, everyone. This is the first Ethics for Lunch for 2023. I'm just now starting our recording of this session. I'm asking that when you come in, you mute yourself. I'll ask our speakers to unmute themselves before you start speaking. We're going to give people just a couple more minutes to get signed in today. Again, our CME code for today on the cloud is 62026. Hopefully everyone has their cloud account by now. If you don't, the instructions are on this slide. Again, we have special instructions for social workers who are mandated to sign in and out. Joining the webcast will be your sign in. And at the end of the program today, you'll need to email Tyree Woods, who's on our Ethics Education Subcommittee. Her email is listed below, and that will count as your sign out. I'd like to formally announce that none of our presenters today have anything to disclose or any conflicts of interest in this presentation. Once again, our CME code for today is 62026. If you're a social worker, joining the webcast will count as you're signing in. At the end of the presentation, you'll email Tyree Woods. Her email is listed on this slide. That will count as you're signing out to allow social workers to get CEU credits. We're going to give it just half a minute more and we'll get started. Okay, good afternoon. I'm Karen Smith, Director of Ethics Integration for Henry Ford. And I'd like to welcome you today to Ethics for Lunch, where we're going to talk a little bit about ethics and homelessness. I'm thrilled to have such great co-presenters today. We have Dr. Richard Bryce from Henry Ford Health Detroit Street Medicine, and also Deandra Gourlay, who is the Vice President of Social Service for Volunteers of America, the Detroit Veterans Housing Program. Again, our CME code 62026. Social workers need to email Tyree Woods at the end of this presentation. We have absolutely nothing to disclose today or any conflicts of interest. Our objectives for today is to look a little bit about how the primary ethical principles apply to our homeless patients. We're going to discuss specifically how some of these things relate to veterans. That is a special homeless population and some of the things that the Volunteers of America do to work to serve this special population of homeless persons. And then sharing how through Henry Ford Health and our street medicine program, we also serve to help those in the community who are facing homelessness. In talking about the primary ethical principles, we want to think about the big five in terms of autonomy, how the related concepts, in addition to autonomy, dignity and respect for persons, maybe are focused differently when we're working with homeless persons. Thinking about beneficence and doing good, are we doing everything that we can to help our homeless patients and help them to better their health outcomes? Non-maleficence, what are we doing to prevent or lessen those harms that we might be able to prevent or lessen or have any effect on for persons who are homeless? And what are their special concerns that perhaps we need to really focus on and take consideration of? Are we missing things that we need to look at more closely? Justice, the principle of justice really asks us to treat like persons like, but are we treating homeless patients equally as we are other patients? Or do they perhaps require more help in order to get equal treatment? And how might be some ways or some additional ways that we could work towards doing that? And care and compassion. Are we really showing care and compassion for these individuals and respecting their dignity, even when we may be powerless to change some of their circumstances, or showing care and compassion to those who are autonomously choosing things that may allow them to choose differently than some of our other patients. So just keep these primary principles in mind as we work through this presentation today. I'm going to ask you if you have questions as we go through this to save them to the end or type them in the chat, and we'll try to get back to them. Thinking about justice and equal treatment, rights for treatment, our homeless patients oftentimes come to us through the emergency room. EMTALA directs us to make sure that we provide emergency treatment to everyone in need, regardless of their ability to pay. That means that they get stabilization for emergency measures, not always admission to the hospital. And oftentimes we find that we're treating their acute needs or identifying them, but we have no terrific ongoing methods for providing for ongoing care or chronic conditions. Oftentimes we find that their medical needs are secondary to other concerns, human concerns for food, shelter, housing, water, those sorts of things, and mental health needs, including at times substance abuse needs. So we also want to consider that low health literacy may prevent the ability to read or follow those discharge instructions that we send people when they head out of the ER. We give them that big sheaf of papers. We know that health literacy varies across our city and our counties, and oftentimes we hand these things out without making sure that they actually have adequate understanding. When we're thinking about ethics, we always look at benefits and burdens. And so when I'm thinking about benefits and burdens as it applies to the homeless population, I think one of the biggest burdens is even just access to our health system and access to medical care that they may need, especially for specialty care. Again, we oftentimes see them when they present to the emergency department, and we could address those acute needs, but ongoing care for special needs is hard. Transportation, difficulty in contacting offices to get those appointments set up and getting there. Substance use also is a burden. Sometimes their primary coping mechanisms may prevent them from obtaining medical care, even when the need is great, and that they're using substances and use for that is seen in different ways. Even such things such as smoking, we're unable to smoke here, or other things that they may use in order to help them with coping with their situations. Social anxiety and privacy issues make sharing lots of personal information difficult sometimes. Oftentimes we are now seeing more and more homeless patients that may have animals that are not cared for while the patient gets treatments, or they may have concerns for those sorts of animals or other pets that they may have with them, which also can present a burden or a barrier for them getting care sometimes. When we think about patient autonomy, oftentimes the homeless suffer from conditions which might impair their capacity. Capacity is one of those things that can vary over time. So they might have incapacity that's temporary or permanent. They may also lack traditional families or next of kin that are there and available to act as surrogates. Oftentimes we refer to incapacitated patients' family members to give consent for treatments, and they may not have that. What we want to consider is through our system, if we have a homeless patient, to ask them, who would you want to be your surrogate if you are unable to speak for yourself, and how might we reach them? You can utilize the verbally authorized surrogate template that Ethics developed as a tier 1 policy across the system. So if you find someone who maybe is estranged from their family, but they do have someone that they trust, that they would be willing to have named as their surrogate decision maker, and we have a way to get in touch with them, I encourage you to look towards our policy for verbally authorized surrogates and get that documented in the system when those patients come in and they do have the capacity, maybe not full, complete, complex decision-making capacity, but they do have the capacity to know who they would trust to make their decisions, and have a reason for naming that person. Patients also may have or need legal guardians, and in those cases, we reach out to case management and ask their assistance in getting patients guardians if they're going to need them on a long-term basis. I think that's what I want to go here. Also, ethics is available when we have patients to come in for treatment. We oftentimes treat them under medical necessity, even if they're unable to provide consent. We are always able to do things to patients in order to better their health under medical necessity. If we have patients who come in who are gravely ill or perhaps dying, who have no surrogates, and we are wanting to limit care in order to prevent needless pain and suffering at the end of life, then you need to contact ethics, and ethics could assist physician judgments in limiting care to prevent pain and suffering at the end of life through our unrepresented patient policy. So now I want to turn and introduce you to Deandra Gourlay, who is the Vice President of Social Service and co-chair of the Detroit Veteran Leadership Committee for the Volunteers of America and Michigan Detroit Veterans Housing Program. She's going to talk more, and they're actually our neighbors. So I think we need to know if they do. They're right next to us. Deandra, you're going to have to take yourself off mute. She's going to talk about special programs for veterans.
Perfect. Thank you, Karen. As Karen mentioned, we are right up the road. We're located at John R. and Milwaukee Street, so right a block off of the Boulevard in Woodward. Volunteers of America Michigan has actually been around for over 125 years, and we are the state's largest private provider of veteran services in Michigan. And we focus much of those services in the Metro Detroit area, since that's where the largest population of folks and veterans are. In addition to our veteran focus and our social services, Volunteers of America Michigan also provides low-income senior housing for folks with disabilities. We have thrift stores and many more programs across the state. Next slide, please. So to give you an overview of our programs in Detroit that focus on veterans within our Detroit Veterans Housing Program, we first have a 60-bed transitional housing facility for male veterans experiencing homelessness. So we opened that on Veterans Day, 11/11 in 2011. So we've been providing those services for quite some time here in Detroit. And within that building, we also have a rapid rehousing and homeless prevention program through our supportive services for veteran families grant. So we're working with veterans who may be unsheltered. They may be in a community shelter or in a transitional housing program or precariously housed throughout Detroit, and also 13 counties on the west side of the state. And within that program, we also provide healthcare navigation for our veterans. So while we're looking to get them housed or stably housed, we get them connected to healthcare benefits, whether that's physical or mental health care, and it could be with the VA or to a community provider. We also have housing navigation for our veterans who are considered hard to house, whether it's because of a recent eviction, criminal conviction and history, or anything else that might make them challenging to house. We have a specialized person to work with our veterans one-on-one to find them stable housing. And we also get them connected to benefits, including SSI and SSDI, their service-connected disability, which is through the VA, and other benefits that they may qualify or need. Within that building, we also have our Veteran Food Security Project, which provides emergency food assistance for housed veterans and their families by giving them a box for a week's worth of food that they can access from our building at any time. Or for our literally homeless veterans, they can come to our facility and get a hot meal any day of the week. We're open 7 days a week, 365 days a year. And lastly, our newest program is our Suicide Prevention, Engagement, and Referral for Veterans. That program isn't specifically targeted for homeless veterans, but we know that the homeless veteran population has an increase of suicidality. So this program provides case management and financial assistance to help remove barriers and reduce the risk of suicide in the veteran population and our active duty population. Next slide, please. So our veterans and military members, they identify as a collective. Through their military experience, they form a bond, and their identity becomes an identity not just of themselves, but as a whole. So the military provides the individuals a purpose, a routine, and a mission, and that identity that they have. And you will hear military members, no matter how long they have been out of the service, refer to their fellow veterans, their fellow military members. They act as a collective. And we see that even in our shelter and in our transitional housing facility, that same sort of camaraderie. And many people who lack that structure or focus in their lives, that's their reason for choosing the military. The challenge we see with that is they transition to civilian life and all of that is gone. So we see a lack of structure when they exit the military, a lack of their community. They're returning to a life that they formerly had with people who've continued living since they joined the military, and then a lack of routine as well. Next slide, please. And so that's really where a lot of our challenges start to happen and why we see so many veterans enter our homeless system. So compared to the civilian populations, veterans experience homelessness and suicide at a higher rate. And from within our veteran population that's experiencing homelessness, we see it's much higher for men. So 91% of all homeless veterans are male and 9% are female. So when we talk about the programs we provide, it's not that we're ignoring our female veterans. There's just a significantly higher need for the male veteran population. And a lot of those challenges are mental and physical health factors that start to spiral and lead them to homelessness. I think one important thing I'd really like to note for this group is not all veterans are eligible for VA healthcare. And that's why we see a lot of our veterans accessing community healthcare. And it really has to do with their discharge status. We think of there's honorably discharged and dishonorably discharged, but there's actually a lot of discharge statuses in between. And so we see a large amount of our veterans who are homeless have a discharge status that classifies them as other than honorable. And it means they didn't do something dishonorable, but they were not honorably discharged. And with that, they cannot access VA healthcare. They cannot access VA mental health care, but they can access our programs. And we can work with them to get them connected to community resources. But their lack of support is even more sparse than some of our other veterans who are honorably discharged. And because of the mental health factors that we see from our veterans, whether it's the transition that was challenging or their wartime experience that was challenging, there's a high amount of self-medication in the veteran community. And so with that lack of support post-military, especially for those not honorably discharged veterans, the self-medication and lack of community, we also know that veterans experience lower marriage rates and higher divorce rates. And so they don't have that identity when they exit the military, and we see a lot of that starts to fall away and they end up hitting our homeless system. All right, next slide. All right, so now I'm going to talk about what we are specifically doing here in Detroit to reduce the number of veterans who are entering our homeless system and, stop them from reoccurring in our homeless system. We are part of the Built for Zero movement, which is focused on ending homelessness in the veteran population here in Detroit. Built for Zero is a national movement that communities can join to focus on homelessness in specific populations or as a whole within the community. And we joined in 2015. Since then, we have ensured that we have quality data around our veterans who are experiencing homelessness. And that's some of the biggest challenges with the homeless population is we don't have the data to support the funding or the resources that are needed to move the mark on reducing folks in the system and reoccurring within the system. So we have a real-time veteran by name list, which we call a VBNL, which is a HIPAA compliant list that lists each veteran in our system by name that we case conference on bi-weekly. So all providers working with veterans come together to talk about every veteran in the system, where they're at, what the plan is, who's assisting them in locating housing, and what their other needs might be. We also identified our chronic and reoccurring users of the homeless system and started to assess what their needs are. Why do they keep re-entering? What are we missing as a community? And what do we need to support them so when they become housed, they're stably housed? And we increased the access and assessment points for any veteran who may be at risk of homelessness or is homeless. And we'll provide some of those resources on our last slide. And the most important part is all providers work together. So we see this with all homeless systems is that there's tons of providers touching the same people, but they're not collaborating. So we as a veteran community come together and we collaborate on who's working with what veteran. We try to reassign them to the same provider if they were to re-enter to keep that work together. And then we enhance our support. So if one provider has X, one provider has Z, but we're missing W, we see what we can do as a community to bring that in. All right, next slide. And so here's our celebratory point. With this Built for Zero work, we're one of 2 large cities in the United States who is on the last mile journey. And that means we are close to hitting functional zero for veteran homelessness. And functional zero is defined in a community that homelessness is rare, brief, and non-reoccurring. And current data would show if Detroit was to hit veteran homelessness, summer of 2024 is our goal, we would have no more than 23 veterans in the system at a time. And right now we have less than 125, which is also very exciting. And since 2018, we've seen a reduction in veteran homelessness here by 50%. So we have done a lot of work in our community to really move the mark on ending veteran homelessness and making it rare, brief, and non-reoccurring. There's 2 links there that you all can check out after that, celebrate some of that work and show what we have done as a community to move it. And we did all of that work without adding new housing stock until this past fall. That's when we started to add new supportive housing stock, but all of the reduction in veteran homelessness has happened without adding new housing into our system. All right, last slide. So this goes through some of the resources, and I believe that they will be presented at the end as well. If any veteran needs to get connected to any of the services that Volunteers of America Michigan offers, they can call that 877-509-VETS. And that's for any service from Detroit all the way over to Grand Rapids, they can get connected. And any person, veteran or non-veteran, who is at risk of losing housing or is currently experiencing homelessness can call the Coordinated Assessment Model, or what we call CAM, at 313-305-0311. And then for after hours and weekend supports and for weather like today, we have our warming centers here listed in Detroit, and those are accessible 24 hours a day. And you can see they're specified by certain populations, and the addresses are listed there as well. All right,
Great.
thank you.
Thank you for all that information. Next, Dr. Richard Bryce is going to talk to us about how a special program at Henry Ford Health works to assist the homeless.
Excellent. Well, thank you so much, Karen. You can move on to that next slide. Excellent. So, as was already indicated, I'm a family physician that has been doing street medicine for over 10 years here in Detroit, Michigan. And so, want to kind of give a little bit of the overlay of what's happening, even on a cold, rainy day, icy day like it is today. If you look at the data, in the year 2021, that was the last time it was reported in the city of Detroit. There was over 5,000 people that had been homeless at some point during that entire year. And so I can tell you right now, there are people that are on the street, underneath bridges, underneath Hart Plaza that are homeless as we speak and are trying to survive the elements, but to survive some of the other challenges that they face as well. If we think about their health, especially from a medical standpoint, we know that their morbidity and mortality is much, much worse. And in fact, for somebody that would be a sheltered homeless person, their mortality may be 3 times worse than somebody that is unsheltered. And I'm sorry, 3 times worse than somebody that is housed. And if you are unsheltered, which we call rough sleeping, your mortality may be 10 times worse than somebody that is housed. And so this is a crisis for many of our patients. And we know that they are dealing with many, many challenges, some of them medical and physical, but we know in terms of psychological, addiction, and even the system challenges that are brought to them, which we'll talk about, are things that we need to address and try not to ignore. And so if we look at kind of the street medicine movement, and this is not something that's only located here in Detroit, this is something that's occurring throughout our country and actually as well throughout the world, of what can we do to help provide care for our vulnerable population, because we know that their health is definitely affected by the challenges of their living situation. And so kind of the classic quote that you will hear often if you read any of the street medicine literature or participate in any street medicine, you'll hear go to the people, right? And so understanding that where they lay or where they sit is something that is that we want to give respect to them and go to them and not just ignore them. And so that's really, really important. I would say, and especially for doing this for many years, our patient population is incredible. We work with a lot of students and residents, and they understand their role with that, and they're always willing to give back. And sometimes I would even say we often take more from them than we give, but we do our best to try to provide the best care that we can and give them the best resources, which we'll talk about as well. The other thing that's really, really important to understand, as I mentioned, the mortality risk that our patient populations deal with is that people are dying. When you are homeless, your rate of death is so much higher. And I think our role in this is what can we do to slow that process? What can we do to be there for our population so they don't die alone? And in the end, we are part of the same community. They're part of our family. And so I think we need to do the best that we can to provide that care and show that love and compassion that they deserve as well. Next slide. So when we look at a model of kind of utilizing street medicine, in the city of Detroit, we've kind of partnered, and Henry Ford has done a really great job, and I think there's some awesome things coming. But this has really been something that has come from the student level. So if you look at Street Medicine Detroit, this is an organization that came from Wayne State University School of Medicine, and Detroit Street Care came from Michigan State College of Osteopathic medicine. But really, the mission is trying to put things in a perspective of what we do. And so, of course, we want to ensure access to quality primary and preventative care for unreached and service-resistant population, bridge gaps between individuals experiencing homelessness and the medical communities, which unfortunately often is very much severed, address the bigger picture, right? Housing, psychological, economic, and social needs. And then we have utilized this as a unique model for medical education, really trying to work on helping our students and our residents to deal with the dehumanization that often comes with our patient population that is dealing with homelessness. Next slide. So what do we do? So there's a few things that we do. There's kind of a classic term that we use here. It's called street runs. Sometimes you hear the term street rounds, but the main thing is going to the people we have to go. And so there's kind of two ways that we do this. They're either called street-based or shelter-based runs. And so street-based run is something that will go out in a team, as you can see in a van like in this picture, and we're going to go around the city looking for patients that may be dealing with homelessness. Once again, we're going to be very respectful about their space. We consider that to be their home. And if they don't need any help or service from this, then we'll just move on to the next person, which is understandable. Really, really important though, as time has progressed, we have been much better at kind of creating our own patient-like panels. And so when we go out, we're very focused on where we're going to go, what services and resources we're going to try to find for those patients. Now, The second type of street run is what's called a shelter-based run. So this would be that we go to a shelter or like a soup kitchen, and when we're there, we're going to kind of set up our shop. We have multiple bags that have treatment equipment, diagnostic equipment, other resources that we can share with our patients as well. And so that when we're in that setting, then they can come up to us kind of at their own choice. What do we do when we're in either situation where we're going to be providing care just like we would if we were in a clinic? We're going to examine, diagnose, treat. No question that we have to show extraordinary compassion. And then probably more important than the medicine that we often do is trying to connect patients to other resources, right? Whether that's housing. For example, in many of our street runs, we do have housing navigators that come from the city, which is great. We're going to try to connect them with the primary care physician. If they're food insecure, try to get them food, substance use services as well, psychiatric services. And so understanding that these social determinants play such a role in this vulnerable population. Now at the same time, we don't really consider ourselves to be the emergency department, and we're not really the primary care physician as well. So we like to kind of consider ourselves to be the bridge to the primary care. And so if we have to get somebody medicines for a month, knowing that they're going to have an appointment in a couple weeks, we will definitely do that. But that's where we kind of identify our role in this at this time. Karen, can we go to the next slide? Excellent. So just to try to get a better understanding of who our patients are and kind of the lives that they live. As we know, if we're talking about from a society standpoint, even from a medical standpoint, we ignore this population often, and we blame this population often for the issues that they're dealing with. And we know that it is way more complex than that. But I think really trying to understand who the people are, I wanted to give you guys some quotes of some of our patients that we've had in the past. So the first quote is, I forgot what it felt like to hold hands. Next. I've never been this lonely in my life. Next. And I don't remember the last time someone touched me. So when you're dealing with all of these other challenges, food insecurity, housing insecurity, the stress on your health that creates, and then on top of it, you start to add in the psychological challenges, the loneliness. This can be very, very difficult. And I think it's really, really important that we identify that so we can continue to understand and provide the best care possible. Next slide. So a couple cool things that I want to share with you, especially everybody here that's in Henry Ford, and this is something that we've created over the last year we've improved it. We've had this actually out over the last 5 years. But what happens if somebody comes to the hospital that's admitted to the hospital that is dealing with homelessness? And I know Karen had mentioned this earlier. There are limitations in some of our services. I'll give you an example of a patient that I just had about 6 months ago that got admitted to our family medicine service. He was an individual that had been sleeping outside Eastern Market, probably a place many of us had been. He had been sleeping on the hard concrete. Unfortunately, he ended up developing a pressure ulcer on his lower extremity that got infected. And so what did he do? He came to the hospital and he was appropriately treated. He ended up on our floor. He needed IV antibiotics for a couple of days, but fortunately we were able to kind of control the infection, the sepsis, and we were ready to discharge him. And where are we going to discharge him? The plan is to discharge him exactly to the place that caused the problem in the first place. And I think kind of the reason we're all in this setting, right? We're in the hospital like Henry Ford is we want to help. And when you're dealt with that type of consequence, it just doesn't make any sense. That's not why we went into doing the work that we do. And so for us, we do have something unique here. It's called the Henry Ford Hospital Street Medicine Consult Service. This is run by volunteers, run by medical students and some other attendings. And really what this allows us to do within Epic, you can put in a consult into street medicine. So if you just go into Epic and you put in street medicine, it'll pop up. Of course, we want to know why you want the consult, when the patient's going to get discharged, and we want to try to get there as soon as we can. Of course, finding out last minute can be a difficult challenge. We also are in Halo, so it's called HFHS Street Medicine. So you can send a message to kind of update the team as well. And it does say that when you do put in the consult. And what do we do for this consult service? Well, what we're trying to do is close the loop on the challenges that patients may be facing, right? So one thing that we always hear is, this patient is homeless. They're non-compliant, right? I see that often, and I think that always frustrates me because what does it mean to be non-compliant? I can't take my medicine because I'm more focused on where I'm going to stay tonight or the food that I'm trying to get. If we look at that, that doesn't really make sense. And so what we're trying to do is address some of those needs. That could be trying to get them to their follow-up appointments, which we do. try to connect them with primary care, ID restoration, getting them their medications, helping them with housing as well. And then we are also going to try to close that loop by following up with the patient after they are discharged from the hospital, wherever they may be. So it's trying to set up a schedule that we can utilize on those community outreach and street runs that I talked about before. Excellent. Next slide. Perfect. So then in closing, I just want to kind of share a patient story, which was something that I think will kind of put this into context of a patient that I've been following for the last couple of years and unfortunately was admitted to the hospital just about a week or so ago. And the story for this patient is that she is somebody that unfortunately has been dealing with substance use disorder, specifically with opioids, had been living in an abandoned warehouse, her and her partner. And in this situation, she had, you know, been dealing with utilizing things like heroin and fentanyl over the last couple of years. And we had been fortunately able to set her up utilizing medication-assisted treatment to get her on Suboxone. And so that had been a positive. She had been getting the correct treatment. Not to make the story too complicated, but in this process over the last couple of years, she did get pregnant. But as you guys are well aware of, when we're talking about addiction, relapse is part of the disease. And unfortunately, she's done really, really well at times, and there's been other times she hasn't done as well. And so a couple of weeks ago, she did relapse. And then what she was doing to make sure that she could utilize her heroin is she doesn't have very good access to other veins in her body. She was using her neck to use the IV drug, and she got an infection and a pretty bad abscess. Unfortunately, one of our teams was out and they saw her. They really encouraged her to go to the hospital. And she didn't feel comfortable going to the hospital and wanted just some oral antibiotics. Challenge, though, as we probably are well aware of, that wasn't going to do enough for this severe infection. And as it started to grow, she was able to get to the hospital. And so she came to Henry Ford. Fortunately, she was treated. She actually went to the operating room, and they were able to do a incision and drainage and clean out this abscess that she had in her neck. After that occurred, she was supposed to stay in the hospital overnight to make sure the infection was under control and she could get the correct antibiotics on discharge. The challenge is she has a partner that also is a patient that is homeless, patient of mine as well, that deals with substance use disorder. And she he couldn't stay in the hospital with her. And because of that, she made the decision that she was going to leave against medical advice. Unfortunately, they didn't even give her the antibiotics on discharge that possibly could work. And she had to just deal with the stress of trying to figure out and navigate the system that's trying to help her, but some of the limitations of her situation can be very, very difficult. And so I can give you good news though, is fortunately one of our residents was on the service and I found out the next morning that she did leave against medical advice. One of our street teams was able to go out on the next day. They were able to get her the antibiotics, and then she was able to follow up with me at Chaz the next week, and her abscess looks great. And she's back on track. We have her back on the Suboxone, and we're trying to do the best that we can to deal with her addiction. And so the reason I share that story, though, is there's no simple solution to this problem, right? Like the answer to homelessness is not more housing. Housing is a part of it, but it kind of shows the bigger situation that there's so much that is there. What I encourage all of us to think about, though, is what can we all do? We all deal with patients like this, whether that's in the hospital or within our clinics, or even if it's on the day-to-day, pulling off the exit of a highway, seeing patients. And I don't know what the solution is. I know that it's complex, but I know that whatever that solution is has to come from a place of love. And so whatever we can do to show that love to our patient population is really the best hope that we have. And so I appreciate you listening to me today, and I'm excited to hear any of the questions that may be coming forward. Next, Karen.
Okay, great. Thank you for that wonderful patient story. And I'm happy to hear that it turned out as well as it has due to the efforts of your team. Just to let people know, these resources I have on these two slides, this one came from some of our ethics education team, and this one again from Deandra. I'm going to put these together on a Word document. They will be on our Ethics in Healthcare webpage, as will this whole presentation. It appears I've gotten some halo messages throughout the presentation that there may have been some concerns with our link today, but it will be posted on our Ethics in Healthcare webpage soon. I think we have about a little over 15 minutes now for questions. I'm going to ask that you write your questions in the chat box. So we'll ask them to our presenters And again, reminding social workers that in order to get your CEUs, you need to email Tyree Woods at the end of this program. Any final words from our presenters while we're looking for questions? Richard, do you know how many homeless patients we see here or we admit at Henry Ford, Maine? Do we track them in any way?
That's a great question, Karen. There are some ways that we sort of track, but I'm going to be honest that it's not very accurate. I'll tell you why. But if you look at so there are ICD-10 codes that we can see within a patient's chart that says there's ICD-10 multiple homeless codes that we can utilize. So that could give us some understanding. If some of you are familiar with, there's our social determinants of health wheel that we also use. That can be questions that we're asking, focus on the social determinants. But I think the bigger issue that comes up often is, especially when we're talking about social determinants and we're talking about housing status, is that we don't even ask. And I think part of that is we don't want to know because we may not have a solution to the problem. And so we just want to focus more on the medical issue. But, in some of the stories that I shared today, the challenge that comes with that is if we don't understand that, then can we really provide the best care? And so, I'm hoping as we go forward, especially with talks like this and continuing, I don't think people are doing this on purpose, but I just think that the system needs to understand, hey, how can we continue to understand this issue that we have, learn from it better to provide that better care because they are part of our patient population and our family, and we can be better. There's no question.
So a question in the chat is that when a homeless patient or a homeless veteran comes into our emergency room, is case management notified in order to make some of these referrals? And I think you kind of answered that, but I'm wondering if you know anything specifically about that.
I do. I think our case management team, whether it's in the emergency department, I'm very familiar with them, or in other parts of the hospital, do an incredible job. I would be honest, so I think their hands are very much tied because the solution often is, okay, so you're in the hospital, we're going to discharge you, and we're going to say, well, you can't stay in the hospital anymore, which makes sense. But our solution is just go to a shelter. And I don't want to say that the shelters are an option. There's no question, but there are many patients that are very resistant to go to a shelter as well. And so when you get to that point, then what do we do? Where are we at? And that's how I think some of our patients that have come to the hospital, they end up back on the streets, which, as we know, has worsening health consequences. But to answer the main question is, yeah, I think the case managers are notified. I know that the emergency department specifically works very closely with the CAM that Deandra had kind of talked about as a place to get resources. But I will be honest that the resources are limited. There are more patients that are homeless than there are houses to place them at this point. And then the other challenge is when you're trying to get somebody housed, there is a process that is kind of based on supply and demand. So sometimes it's a few months, sometimes it's a few years, and unfortunately, that can be very difficult.
Yeah. Another question that someone wants to know, since Henry Ford Health goes across a while, is the Detroit Street Medicine just available in Detroit, or does it also utilize downriver? And Deandra, I know you have some resources that are over there. So maybe Richard, if you could address Detroit Street Medicine, and then Deandra, if you could address what resources and how to attach those for our downriver patients.
Hey, great question. So specifically for us here in Detroit, working with Wayne State and Michigan State, that we're located in Detroit, I can tell you that there are other street medicine organizations associated with MSU and Henry Ford. Like there's one in Macomb County, there is one in Pontiac, there is one in Lansing as well. There's nothing specific downriver, but that doesn't mean that couldn't. And I can tell you we have had referrals downriver or to other parts of Wayne and Oakland County. But that's not typically where we end up just based on the need, at least at this point.
Yeah, and for downriver, I spoke about what we're doing in Detroit, Hamtramck, and Highland Park as a continuum of care. Downriver would fall in what is out Wayne. It's the rest of Wayne County's continuum of care. And you can access that through Wayne Metro Community Action Agency. They're the lead agency, or I'll put the phone number in the chat, but it's 734-284-6999, and they can get connected to services that way.
Oh, that's great. Thank you, Deandra. The next question concerns ICD codes. And Aaron wants to know, would you say our ICD-10 codes are underutilized at Henry Ford on the whole? And what opportunity is there for provider education in this space? You're laughing.
The answer is yes. It is. I think there's specifically related to homelessness, that's a bigger challenge, right? Because of course, we want to do the best of coding that we can, but we know this. If you ever look at any research based on coding, is that people are always going to undercode because it takes more time and it doesn't necessarily provide better care, but it could give better information kind of from a population standpoint. So that is something that we can learn. I think though the bigger issue when we're talking about ICD-10 coding for homelessness is that do we even know somebody's homeless? Do we actually ask? And then what do we do about that? That's kind of a bigger picture there. And that could be another reason to add on why we undercode based on ICD-10 code for homelessness.
You know, I think a related question is brought up by Dr. Erin Field, and she's saying that she didn't hear about street medicine until one of her students shared it with her. And she's saying, you know, it'd be great to hear more on when you think we should utilize this as a consult and how to do that. But I think it's related to some of the things you've said about just knowing that someone's homeless.
Yeah, and for Dr. Fields, yeah, the consult's for anybody. So if anybody wants to put in a consult, we have a team that can go. I think probably that next step though is continuing to provide information about what we do. I do know over this past year, like, and maybe we can do this for surgery as well. Of we've been to grand rounds, we've been to other like didactic sessions, specifically more on the education side, just because it's easier to kind of present at something like internal medicine grand rounds, family medicine didactics. We also have met with case managers in their case management meeting as well, just to so that we can kind of share information and try to figure out how we can solve this together. But we can definitely share that information for any department that would be interested.
One of the things I noticed, Richard, on the slide that you put up with the EPIC ordering is it said, has the patient been advised of this, yes or no? Is that a requirement for having them? Maybe I'll see if I can slip back to that slide again just to show it.
Yeah, we do want to get the patient buy into it. There's a reason for that because it's similar to like saying like, oh, you can't stay in the hospital. Just go to a shelter. Like the shelter's like this perfect option. And so some patients, they may be homeless, but they may not want any services from street medicine, and that's okay. But that's why we just want to ask them so that they are comfortable and they know that we're coming. And so that's kind of where that question comes from.
A specific question from the ortho service line, Tamara Crizel says, we're in the ortho clinic and we see homeless patients with foot, ankle, or other wounds. How do we order that, or is ambulatory case management a better referral?
Great question. I'm not sure. And in some of the meetings I've had with ambulatory case management, I know there's challenges of how do we going to provide care to somebody that's on the street. This is what we do. So the referral for consult to street medicine is obviously more on the inpatient side at this point. But if you have a patient that you want us to follow up with, we definitely can do that. And the nice thing, it's not just, you know, there are multiple people that are doing street medicine. So I should have mentioned this in the presentation, but like, for example, I will be going out in a couple hours again, but we probably have teams that are going out at least 4 or 5 times a week, all volunteer though, which is pretty incredible based on the passion of the students and residents and other attendings that are out there, as well as some other awesome nurses that work with us. And so, and social workers, I should say, I don't want to not include anybody, but the main point is we communicate very well with each other. And so if there's somebody I see today that needs to be seen in 2 days, we do a great job of communicating. So if you have somebody specifically with wound care, following up on that, we've seen it before, and we would definitely be appreciative if you let us know, because we can definitely help if that's something you need.
This is kind of a general question from Pastor Deborah, who sits on our ethics committee. Wants to know if there's any way that the Volunteers of America or the street medicine team have teamed up with local churches. Deandra, has the veterans work teamed up with local churches?
So Volunteers of America Michigan is actually a church. We're not a pulpit church. We're a church in action. So we do work closely with some churches, but it is actually on our list to get better at teaming up with local churches. So Pastor Deborah, I put my email address in the chat. You can email me and we can do that.
Great. Here we're making connections. I love it. Anything?
Yeah, and then the answer for us from Street Medicine is yeah, that there are multiple churches that we work with because a lot of the churches are people that are gonna or the organizations that are gonna be running soup kitchens as well as shelters like the Pope Francis Center, Detroit Rescue Mission, the Salvation Army, Spirit of Hope, just to name a few churches. So absolutely.
Okay. And one question from someone at Macomb, Donna Kennedy Williams wants to know, can we donate supplies, medicines, or anything for wounds, and how might that be done?
Absolutely. So, and I can put my email in the chat too. If you actually just go to Street Medicine Detroit, that's the website. It's streetmedicinedetroit.com or search it. There's an option to donate there as well, which is pretty straightforward. But let me put my name in or email in the chat if you got anything else.
Yeah, put your website and your email in there, and that would be great. And I think we have Deandra's in there too. I want to thank both of you again. Just to give last chance in case any final questions come in, but I think this has been such an informative session. I know I certainly have learned a lot from the both of you in the last couple of weeks and putting this together, and I'm sure everyone else has as well. As Richard said, I think that, we have to treat these patients with love and beneficence and kindness of what we're doing. And I think a lot of times people just don't know what to do. So I really want to thank you both for all of the great work you do and for sharing it with us so that we could all do more and do better.
Thank you so much for having me.
Yes, me as well. Thank you so much.
Okay, guys, I think I'll give everyone a couple minutes left. I hope everyone travels safely home today as the weather is supposed to get bad. And thank you for joining our first Ethics for Lunch for this year. We'll see you all again in April. Thank you. And I've stopped sharing.